This recording will cover part 2 of asthma. First, we're going to start off with talking about interventions or solutions, or how we take action to either control asthma or to address an acute asthma attack once it has started. And the two things we're going to talk about are the personal asthma action plan and also medications. Good management of asthma requires that the patient do a lot of monitoring of their respiratory status, that they're able to self-manage medications based on their lung function tests, such as when they're using that peak flow meter, and I'll talk about that in a minute, and that they know when to consult their primary healthcare provider. Priority nursing actions focus on patient education about using his or her personal asthma action plan, which includes drug therapy and lifestyle management strategies. Ideally, a personal asthma action plan is developed with the healthcare provider and the patient and is tailored to address the patient's personal triggers of asthma, their asthma signs and symptoms, and drug responses. It includes a list of the daily controller drugs, so the medications they're taking on a daily basis to maintain control of the asthma, as well as information about the medications they're using as reliever drugs or rescue drugs. A lot of times you hear a patient talk about their rescue inhaler. It'll have patient-specific daily asthma control assessment questions. So the patient will self-assess to see how well their asthma is being controlled. It'll contain information about when to contact the healthcare provider and when emergency actions are needed when the asthma is not responding to controller or reliever medications. The patient should assess their asthma severity at least daily with a peak flow meter. And here at the bottom right on the screen, you can see what a peak flow meter looks like. So with an asthma action plan, the patient knows what their baseline peak expiratory flow measurement is. So they've done a couple runs and got their personal best of what number they would expect this little red marker to land on when they exhale forcefully and quickly into that peak flow meter. And the patient should be then checking using this peak flow meter daily to assess if there's any improvement, but more the big concern is if that number starts trending downwards, that they maybe need to tweak their medications. And they use that asthma action plan. It spells out to them if you land in these two numbers. So we'll just say, for example, that their personal best is 400, and it says if you land anywhere between 350 to 400, you're green, you're good to go. So if you're landing in that green area, you know that your asthma is well controlled and you continue with your regular daily medication you're taking for asthma and no additional medication is needed. If you get a reading in the yellow, so yellow is sort of like caution, right? So we know that in the yellow, maybe the asthma isn't being as controlled as well as it could be. We'll see an increased use of reliever drugs, indicating that the asthma plan needs to be reassessed, and maybe those daily maintenance drugs need to be tweaked so the patient doesn't have to rely on the reliever drug or a rescue inhaler. Frequent readings in the yellow zone or increasing use of reliever drugs indicates the need to reassess the asthma plan for the need to change the controller drug. So we had said that might want to change their baseline medications or their daily medications, I should say, to try and get the patient back into green readings on a regular basis. And if the patient were to use their peak flow meter and get a number that has been marked as in the red zone, that would indicate a serious respiratory obstruction. They would need to immediately use the reliever medication or that rescue inhaler and seek emergency help. All right, so let's look at the medications that are used to treat asthma. So the first classification, the one that you're probably most familiar with, are bronchodilators. And just like they sound, just like the name says, rather, they dilate, so they widen airways. That's their job. They cause bronchodilation through relaxing bronchiolar smooth muscle by binding to and activating pulmonary beta-2 receptors. Your prototype bronchodilator that I want you to be familiar with is albuterol. While there are different types of bronchodilators, whether they're short-acting beta-2 agonists or long-acting beta-2 agonists, one clue that you'll have that you're dealing with a beta-2 agonist is the ending TEROL. So if you see that, you'll know that you're dealing with a beta-2 agonist. Doesn't give you information whether it's short-acting or long-acting. So short-acting works quick, long-acting takes longer. The short-acting albuterol is frequently used as a reliever drug or a rescue inhaler for patients. And it's important when looking at medications for asthma that you know which one is used for rescue, right? Because if your patient's having an acute asthma attack, we don't want them to grab a medication that isn't rapidly acting, because that's not going to help them. Albuterol is a medication that is acts quickly. It's a short-acting beta-2 agonist that will provide fast relief for the patient. So this albuterol, the short-acting beta-2 agonist, primarily use as a fast-acting reliever or rescue drug to be used either during an asthma attack or just before engaging in activity that usually triggers an attack. We want to make sure our patients with asthma know to carry their rescue inhalers such as albuterol with them at all times. Know that it can cause tachycardia. Be able to provide patient teaching about how to use a meter dose inhaler like albuterol. So if the patient's going to be taking 2 puffs of albuterol, we don't want them taking those back to back, which patients frequently do. We'll want them to take 1 puff of albuterol and then wait 1 to 2 minutes for that second puff of albuterol. If they're taking 2 different types of inhaled medication, albuterol will always be the first inhaler used. And after taking a puff of albuterol, the patient would want to wait 5 minutes before using a different type of inhaled medication. The next type of medication we'll talk about are cholinergic antagonists. You know, antagonists are blockers. They cause bronchodilation by inhibiting the parasympathetic nervous system, allowing the sympathetic system to dominate, releasing norepinephrine that activates beta-2 receptors. The purpose is to relieve and prevent asthma and improve gas exchange. The prototype cholinergic antagonist you need to be familiar with is ipratropium. The cholinergic antagonist you'll recognize by the ending tropium. And again, ipratropium alone isn't a rescue medication. So albuterol is what we're saying is our rescue fast-acting medication. If your patient was having an acute asthma attack, they would not want to inhale ipratropium alone. That would not help with their asthma attack. One medication that you may hear of in the clinical setting is dual-neb. So you might hear of your patient getting a dual-neb treatment. Dual meaning 2. Neb meaning nebulized treatment, and the 2 medications that are included in a dual neb are albuterol and ipratropium. So it's a combination of short-acting beta-2 agonists as well as a cholinergic antagonist. So both bronchodilators and cholinergic antagonists improve airflow by causing bronchodilation. Anti-inflammatories, on the other hand, they do not change the lumen of the bronchiole, right? In a sense that they don't affect the smooth muscles and relaxing them so that the airway gets bigger. Anti-inflammatories improve airflow by increasing gas exchange by decreasing the inflammatory response of the mucous membranes in the airway. So they don't cause bronchodilation, but they do decrease inflammation, which is what leads to a larger airway, how they help to contribute with improved airflow. So hopefully you all remember that corticosteroids are anti-inflammatories, and you can recognize those medications because of the endings "sone" and "solone." So if you see something that ends in "sone," like fluticasone, it should trigger in your brain, oh, that's a corticosteroid, it's an anti-inflammatory, I know how that's going to help my patient. One of the things with patient teaching, if you remember, they can cause problems with infections. When a patient's using an inhaled corticosteroid, they want to make sure they rinse out their mouth after inhaling it to help to reduce the likelihood of them developing a yeast infection in their mouth. And so the steroid can be delivered as an inhaled medication. The patient may be prescribed oral prednisone to sort of get asthma under control. And in the acute setting in the hospital, the patient may receive IV steroids to help with inflammation and improve gas exchange. Another classification is chromone, works by stabilizing the membranes of mast cells and prevents the release of inflammatory mediators. The purpose is to prevent the asthma attack triggered by inflammation of allergens. Leukotriene modifiers block the leukotriene receptor, preventing the inflammatory mediator from stimulating inflammation. So when I see leukotriene, I think of histamine. They're both chemical mediators that can lead to inflammation. The purpose of the leukotriene modifier is to prevent asthma attacks triggered by inflammation and allergies. And montelukast is your prototype medication that you'll need to recognize. So again, looking at the different classifications and the medications that are shown here, which one is the one that you identify as being a rescue medication or a reliever medication? Hopefully you're picking the albuterol. This is the medication, again, that the patient would use during an acute asthma attack. So in terms of evaluation, what are we going to see in our patient when treatment for asthma is effective? Decreased signs and symptoms, whether it's well-maintained asthma where they're not having acute exacerbations or asthma attacks, or if during an asthma attack we start to see the patient's signs and symptoms improving. So a decrease in wheezing, their pulse ox starts to increase, right? Anything that showed signs and symptoms of improved oxygenation. We're going to come back to our interventions and talk about two other interventions I didn't talk about yet. So we did talk about the personal asthma action plan and also medications. Another thing is regular exercise and activity. Regular exercise is a recommended part of asthma therapy to maintain cardiac health, strengthen muscles, and promote gas exchange and perfusion. We want to teach patients to examine the conditions that trigger their attack and adjust the exercise routines as needed. Some may need to use their fast-acting inhaler prior to beginning an activity. Another intervention is obviously oxygen therapy. Supplemental oxygen by mask or nasal cannula is often used during an acute asthma attack. High flow delivery systems may be used when bronchospasms are severe and limit flow of oxygen through the bronchial tubes. Status asthmaticus is a severe, life-threatening acute episode of obstruction that intensifies once it begins and often does not respond to usual therapy. Monitor for extremely labored breathing, wheezing, accessory muscles, and distension of neck veins. If the condition is reversed, patient may develop a pneumothorax or cardiac or respiratory arrest. I put in a knot there. If the condition is not reversed, patient could develop a pneumo or go into cardiac or respiratory arrest. IV fluids, potent systemic bronchodilators, so we're talking about through the IV, throughout the whole system. Steroids, epinephrine, and oxygen are frequently used. MAC sulfate may also be used. We want to prepare for emergency intubation. Watch for a sudden absence of wheezing, which would indicate total occlusion of the airway and require a tracheotomy.